And we're going to go ahead and get started. Thank you all for joining us. Today's webinar is Domestic Violence, Trauma, and Substance Abuse, the first of our new webinar series for substance abuse counselors and other allied behavioral health professionals working with women. Our trainers today will be Patti Bland, MA, CDP, and Director of Substance Abuse Training and Technical Assistance for the National Center on Domestic Violence, Trauma, and Mental Health. Patti will be joined today by Barb Rindels from the Integrative Services Project in Iowa, who will also be helping to lead today's webinar. Before we get started, I'll go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are also explained in the Using this WebEx System tab in the upper left-hand side of your screen. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have any questions regarding the training content. You may contact Jennifer Curley, also with the Center, if you have any questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You will see a lot of options, but for this session, you'll select all participants if you would like to respond to a question from the trainer or to get in contact with me any time during the session. You should click on Jennifer Curley to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on all participants, type in the program you are calling from, and then press enter. Great. Thought for a second maybe it wasn't working. Okay, perfect. Thank you all so much. Y'all can continue to do that if you'd like. While folks can get a lot out of the chat feature, there are times when it moves really quickly, sort of like just a moment ago, and it can feel a little bit distracting. If this is true for you, you can feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will provide live captioning during this webinar. Below the chat box, there is a media viewer box. This will contain the captions. If you do not want to see the captions, click the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. At the end of the webinar, you'll be taken to a very brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, please return to the email you received with the original webinar link and re-enter the training. If you're experiencing technical difficulties and are unable to contact Jennifer Curley, you may call the WebEx tech support to resolve any additional issues. That number is 1-866-229-3239, and we will also post this in the chat box. Lastly, I want to let you all know that we've been experiencing some bad storms in Chicago today that have caused power outages throughout the city. And while it appears that things are running smoothly at the moment, there's a possibility that we might get disconnected at some point. If this does happen, you'll get an email from me with information about how we will proceed. And hopefully this won't be a problem, but I just wanted to fill you all in prior to anything happening or in the event that you hear thunder in the background or something, just in case. So thank you all for joining us today, and I will now turn the training over to Patti and Barb.
Hi, everybody. It's so nice of you to join us today, although I have to say it has been thundering and lightning somewhat. I am delighted that you're all here, and I'm delighted that Barbara can join me as well. Before we start on with the formal part of the program, I'm so happy so many of you have joined. I could barely see all the names fly up, but I did want to say hi to Marcy Lopez, who's on here from Hawaii, because when I walked into the office today, I had got a cute note from her and 2 little pens, so I wanted to say thank you, Marcy. And also, I see someone I haven't seen in a long time, all the way from Alaska, Cheryl Elishansky. And Cheryl, would you believe it? I had on the Village of IAC t-shirt yesterday. If I knew you were going to be on, I would have wore it today. So welcome to you and everyone else who is here with us today. Barb, did you want to say hi?
Hello, everyone.
Thank you for joining us again, and I'm going to move along if I can remember how to make the slide go to the next one. Let's keep our fingers crossed. No, that's not working. I forgot. Should have had Jen show me how to move the slides when we were... Oh, thank you. Thank you for your patience. So Well, this particular workshop is on support groups and is fairly practical in nature. It's always wise to mention that when you hear about domestic violence and sexual assault, substance abuse, and other forms of oppression, that it can indeed bring up unexpected feelings and responses. And so we encourage you to turn down the volume or take a break if something is overwhelming your emotions or you find it difficult, and to seek additional help when needed. We also encourage people attending webinars, if when they hear difficult material, to debrief with a trusted individual. We also have information at the end of the webinar that gives a list of trauma-informed resources and where you can also get support and information. So sort of as a preamble to beginning, I wanted to tell you a little bit about how it is that we organize our work and what we're thinking about when we are providing support groups for people experiencing multiple problems. So when I am, and my colleague Barb and others are thinking about substance use and substance abuse coercion and how that harms people and prevents them from getting either safe or sober or both, as the case may be, we are looking at groups that have a human rights and social justice lens. So we are looking at what is going on in this person's life within the context of their life. And we're looking at things from the cultural community lens. What may fly in New York may look different in Juneau or IAC. What may work in Iowa may be different if you're in Colorado. But there are many things that are common themes, and yet all the work needs to be adjusted so that it will work in our local communities. And I think with support groups, for those of us who are here that are from rural areas, many of us are well aware that people won't even attend a support group because if the community is small enough, it may be overwhelming in terms of fears around confidentiality. And so sometimes we have to have a potluck supper or have a quilting bee or an event that isn't overtly a group, but that allows people to get the support that they need. So you want to be thinking about things not just from human rights and social justice, but also from culture and community lens, and to be thinking about substance use and substance use coercion in the context of domestic violence and how that prevents people from getting into treatment. It causes people to be pulled out of treatment against medical advice and other kinds of harm that people who hurt others use when domestic violence and substance abuse coexist. Additionally, we like to think of this in terms of trauma, and we have a trauma-informed lens that lets us try to have better empathy and understand that things that people do may not seem to make sense, but actually they make perfect sense when you look at all these pieces that I've just discussed in context and see that if someone has a partner who says, I'll kill you if you go to a meeting, it may make sense that this person doesn't go to a meeting, just to be aware that these elements are present. And at the bottom line for all the work we do is that the work is defined by the people we serve, that our groups should provide physical and emotional safety. There are opportunities to offer hope and resilience, and most importantly, there are opportunities to help develop relationships and connection. It's been our experience that substance use takes place in the context of a relationship with a substance. Domestic violence and sexual assault takes place in, certainly in domestic violence in relationship with a person close to you, and sexual assault many times is someone you know, can be a stranger, but in many cases it's a breach of harm that takes place in the context of a relationship. And we believe that since so much harm takes place in the context of a relationship, that a support group can help begin the healing process and provide opportunities for advocacy and support, as well as counseling with peer support within the context of a relationship as well. Barb, did you want to add anything?
No, sounds good. Sorry. I thought I did, but I lost it.
Well, if you think of it, let me know. And I always talk too much, so bear with me. I've asked Jen if you send a note or an email with a question, that she'll stop me and we'll take time to answer those questions. So feel free to ask a question when you need to, anyone out there. And I'm not going to go over goals and objectives right now because it takes a lot of time. I think that you can read them. And we'll move into the actual support groups, the formats, and topics. I know we have a lot of people on the line today from Iowa and Washington State, and so you may see some people familiar to you here that have worked in Washington or have done training in Iowa on the support group pictures here. So as we move forward, again, I really want to stress that the work we do is all about the relationship, because when you think about the harm that's done from substances, the thing that, like if you got a prescription for a medication and you thought it would heal you or help you, or if you took that drink and felt relaxed, and then all of a sudden it's not that way anymore, the thing that was helpful is hurtful, it's traumatic. And when you think about people you love and you care about turning around and being harmful, it's also traumatic. And so the healing, again, as I said, it has to take place in the context of a relationship in most cases. And so support groups offer a really good opportunity for people to benefit from working in a group setting and being understood by others that have experienced similar problems as well as similar successes. I think it's real important to realize that people do heal, they do get clean and sober, and they do get safe. So interestingly enough, when my friend Debbie Edmond, who worked with me on the safety and sobriety manuals that a lot of you have looked at, we interviewed a lot of people up in Alaska and Washington and Chicago. And interestingly enough, the overwhelming theme that we received, and it was certainly from rural communities, but also in more urban settings, is that people generally don't feel safe unless they're really assured of confidentiality. And I don't think that's a big surprise to anybody, whether you're in the substance abuse field or the domestic violence field. And I think that when we're talking about support groups for survivors of domestic violence and sexual assault who experience a substance use disorder, it's often really helpful if we can have those groups co-facilitated by someone from the substance use arena and someone from the domestic violence sexual assault arena. And because of that, it's helpful for everybody to know what the requirements are. So, I don't have time to do a full confidentiality webinar right now, and I didn't think you signed up for that, but there are federal, state, and local guidelines regarding confidentiality that everyone needs to be familiar with before they partner to do support groups together. And I thought it might be helpful for advocates who are listening to know that the substance abuse professionals respond to 42 CFR, and they have federal regulations. And those are very strict, and they're probably the best group of people you can co-facilitate with because they take confidentiality extremely seriously. And for those of you that come from the substance use or behavioral health arena, you would want to know that advocates working in domestic violence programs have VAWA regulations, Violence Against Women Act regulations, that also mandate significant confidentiality safety rules and guidelines. And I have posted on this slide information so that both substance abuse professionals and advocates can look and see what the requirements are at the federal level. It will be really helpful if you share with each other in your community what the local requirements are, and also that if you are doing groups together, that if you're a substance abuse program or a domestic violence sexual assault program, that you get that MOU or memorandum of understanding or memorandum of agreement in place before you begin. And I would have to say some people have leaped right into doing groups, but it tends to be if people spend a little time talking about what they're hoping for, their baseline desires are, what the clinical issues are that you may be addressing if the groups are done in a treatment setting, and what the safety and advocacy concerns are if groups are done in a DV setting, or if we're looking at both issues in tandem together, how do we go back and forth? To have those kinds of discussions are really, really helpful. And I know that Iowa has rolled out information regarding substance abuse and domestic violence and has programs that are working together. And I'm wondering, Barb, if you wouldn't care to talk a little bit about some of that early group work.
Yeah, I was just going to say, we also, besides an MOU, some people call it a qualified service agreement. Anyway, in Iowa, that's what we talk about, to have the agencies covered under confidentiality while working together. But that doesn't cover individual confidentiality with the clients, and so it's best still to have releases from the clients if they need some help with a letter written or a case management type of thing for them. The other thing, like you suggested, Patty, for them to meet and talk about, especially the two that are going to run a support group, to talk about the dangers of having the group, how to name it, how to talk about confidentiality within the group, and let's see what else. And to help make guidelines for the group with the group participants.
Yeah, that's good. And there are like you said, there are the overarching confidentiality concerns that mediate the field, and there are also confidentiality concerns depending on what setting you're in. And for those of you that are working in clinical settings and that'll be doing support groups primarily on site at a behavioral health program or a treatment or hospital facility, something like that, you know who you have there if it's not a drop-in setting, and you're going to be adhering to the guidelines regarding confidentiality that are mandated for your field. But it would be helpful if you are doing support groups that look at both domestic violence and sexual assault, that you're very, very judicious with what you put in the file. Because even with 42 CFR, courts can ask for, they can get a court order to see information. And one of the things we know is that when a person's in an abusive relationship, an abusive partner will often use the court system or try to use the court system and try to get information. And so I would recommend that what we document regarding domestic violence is fairly limited. And if you're not in a clinical setting, if you're in a shelter setting or in a drop-in group or doing outreach, I used to do support groups at Needle Exchange in Seattle, Washington, and in some drop-in sites. And so even though it was from the substance abuse side where I was talking about DV and sexual assault, I just got first names only and took very limited notes and pretty much documented a topic that was covered and attendance only, as opposed to the specifics that were discussed or covered in the group. And of course, if anyone wanted information, sometimes they wanted information for child welfare or for if they were mandated to go to a support group. Sometimes they might have been in treatment, and one of the groups that was allowed was participation in a domestic violence group. If we had the required release of information, we would disclose that. But I always made it clear to any of the helping systems that were getting information from us that if that in general the groups on domestic violence and sexual assault were more peer-based, and that generally we identified topic and identified attendance, but didn't get into the specifics that were discussed at the time of the group. So these are things to be thinking about, and this is primarily on safety. In a clinical setting, people are doing two things at once. They want to assure safety, but they also want to be able to keep track of the work that is being done. And so when I was in a clinical setting and doing support groups in a treatment setting as opposed to the domestic violence sexual assault arena, I would sometimes keep working notes that would take me from one week to the next. When I got to the second week and would begin the next group, I'd shred the working notes from the week before and again just keep minimal notes. So these are things that you can do that can protect the information and ensure that information that shouldn't get into the hands of an abuser are protected. I'm always having trouble moving my slides, so bear with me. Confidentiality concerns, come on. Why won't it move? Okay, so I think both substance abuse professionals and advocates are really good at advising group participants about what you are indeed mandated to report, but it helps because a lot of times the people we're working with are really afraid of us, and they're often afraid that we're going to report them to child welfare or to adult protective services, things like that. And so what I like to do right at the front end when I'm working with a group is remind them, and I do remind them at every group, that we are mandated to report certain things relevant to child protective services and adult protective service issues and identify what those are. And that also we're required to make a report if someone is threatening suicide and unable to make a contract, etc., or homicidal threats. Those kinds of things are things that are generally mandated reporting. And so that, I think, is really critical to let people know right at the front. And the other thing that's really important when you're doing a support group, whether it's in a domestic violence, sexual assault, or homeless setting, or in treatment, is to acknowledge that, particularly if we're in outpatient treatment, probably less important in inpatient, at least during the initial time that someone is in, is that group members frequently don't want to be greeted or acknowledged outside of group due to safety constraints. So one of the things that we did in our support groups was find out from the group how they wanted to address this. Some groups came up with a code where they might say, oh, can I borrow a pen, or some statement, and if the person was safe to talk, they would speak, and if not, they would just say, no, I don't have any pen. But they had a consistent plan of how they would operate, whether or not they would speak. For me, both as a substance abuse professional, as an advocate, particularly in rural areas, so those of you that are with us today that are in a rural area, you could go up to Walmart or someplace and half the people you're seeing are there on the same day you are, and they'll come up and speak, but some of them, they don't want to be seen talking to you because people are going to make assumptions. So I always would share with the women that that they are in charge, and if they want to speak to me, they should speak first, because I won't go up and just start talking so that they have to explain how it is that they're talking to the person in town who's the advocate and the substance abuse provider. A lot of times they don't want to do that. So these are things to be thinking about in terms of confidentiality that are really critical. And especially, I mean, it's true no matter what setting you're in, but it's extremely true in a rural setting. And now, for people doing, whether you're a substance abuse professional, mental health clinician, behavioral health person, or an advocate, the one thing I want to stress to you is there isn't a one-way, right way to do this kind of work. It's really probably one of the most important things to do is to be very open and very flexible, because on some days the biggest issue is going to be a person who's craving or wants to use, or someone who might have relapsed, or there could be concerns about withdrawal, or it could be very, very substance abuse focused. And the next time you meet the person, it may be all safety issues, safety, safety, safety. There may be court issues coming up. And so one of the things that I have found is that it's important to have a set lecture that you have ready that you can offer someone that they can take with them if it's safe to do so, and if it's not, whether you're in a substance abuse setting or a DV setting, if we have a folder or a place where they can store information that might not be safe for them to bring home, that's really helpful. But to realize that things will come up in a support group that we're not expecting, and you may have a lecture planned, and you may have a person there who's thinking of drinking or using because they have to go to court regarding a protection order and they're terrified of their partner, or vice versa. So every day you've got to be very flexible to be successful. We also found that prioritizing child care was really important. Again, if a person's in inpatient and hopefully they're able to get access to child care or support or help, sometimes that's not always the case. In drop-in settings or in outpatient whenever possible, if there is therapeutic child care or daycare available, that is one thing. The first grant we got to do support groups in Washington State, we got about a small pot of money, about $5,000 to do the groups, and what we did was pay for both child care and an advocate and a substance abuse professional to be able to do the groups together, and that was really important. The other thing we did was recruited volunteers from the alumni of treatment facility, and we recruited volunteers from the domestic violence volunteer programs and sexual assault volunteer programs, also to come in and offer support and be available for both child care and present in support groups if someone needed help with, like we might be doing a regular support group, but there might be someone who can't focus on the support group because they do have a protection order they got to get ready, or their landlord is going to evict them, and so it's helpful to have people available that can provide practical assistance as well as clinical and advocacy support. So these are things I want you to be thinking about. Sort of like thinking kitchen table instead of really formal treatment or formal advocacy. And assistance with transportation. And Barbara, did you want to say? Add?
Yeah, Patty, I just wanted to add that co-leading a group instead of just having one person lead the group, co-leading really helps in that what Patty was saying about maybe someone can't focus or there's an issue where someone has to leave the group to deal with children, say if you're having child care on site, that one person can continue leading while the other one step out to help that other person for the moment of whatever crisis is arising. And then also if there's any need of reports being made to CPS or Department of Human Services, depends on where you're at, that the reports be done with the woman if possible, because especially in Iowa, I guess that if the woman is not part of making the report, and then she could be charged with child endangerment as well. And so try to include the woman as part of the report or making the report herself while being supported by the leaders of the group would be the best route to go.
Yeah. Thanks, Barb. The other thing we found out is again, if you're in inpatient treatment, that's not as big of it's certainly not an issue, but in most settings, whether it's outpatient treatment or domestic violence, sexual assault, many people will need assistance with transportation, and that may be a bus ticket or if you have, I remember I was working with a program up in Alaska, and they were kidding around and they were laughing, and they said, oh, wouldn't it be great, imagine if we had a van and we could drive people to meetings, and they were just doubled over laughing about it because they didn't think they could do it. And then one of them said, hey, we could do this, let's write a grant, and they were able to get a grant and drive women to meetings. So it's just creative thinking, I think, is really helpful. Now, I will tell you something interesting that I learned, and again, this is why it's helpful to have people with experience in both domestic violence and sexual assault, as well as people with a background in alcohol and drug issues, to work together, is because in general what we used to do is hand someone a ticket, so that, a bus ticket if they were able to get a bus, if they're in a community that had that kind of access. You don't have that often in rural areas. But you would get a ticket to go home from the meeting and a ticket to return. So we give out 2 whenever we see you. And we had a new volunteer on, and she handed a woman who was in a support group dealing with issues regarding heroin and domestic violence. She handed her a book of 20 tickets. And I remember the woman in the group looking at the book and looking at the woman and looking at the book, and she said to the woman who gave her that book, I appreciate that you trust me with 20 tickets, but I can convert this to cash on the street. It would pay for a hit or 2, and this is a relapse issue for me to have that in my hand. And I thought it was really brave of that woman to share that, but it was also educational. And so if you create a safe space and people can tell you about it, but it's really helpful for people that are both substance abuse and DV to work together. We were lucky that the person that was receiving services felt strong enough to speak up about what her concern was. And but that, if she hadn't, that could have been a really serious problem if there hadn't been someone there who recognized it as an opportunity for relapse. You don't think about these things sometimes. So it's just something to be thinking about. Initially, I know from in domestic violence, we usually have really elaborate screening processes so that someone could get to a group. But what we found out was that women with substance abuse, about 2/3 of the women that we work with had some prior experience with AA, NA, or some other type of peer group, and understood confidentiality and understood anonymity, and that they often, wanted to call, find out about a meeting, and get there. And that some of the elaborate procedures we had put up made it hard for them to actually access it. So in Washington State, when we began doing it, we made it a drop-in group so that people could come. And not all the groups we did were drop-in, but the first group, the group that we had funded, was a drop-in group. And I want you to know that the group has ran from 1994 to the present day. And to date, I think only one time did somebody drive by that might possibly have been an abusive party. But that willingness to just make it completely accessible for a survivor has provided safety and sobriety options for many, many women, and made it as easy as possible so that they didn't get overwhelmed. The more issues you're facing, if you're facing just domestic violence, or then say add domestic violence and sexual assault, and then add substance abuse, the more things that are happening, the harder it is to deal with any of it. 1 + 1 isn't 2, and 2 + 1 isn't 3. It's 10 tons of trouble. And so you want to make it as easy as possible for people to be able to get the services that they need. It helps to have enough staff and volunteers available. I spent a lot of time when I first began doing this work recruiting volunteers to help me. And we found that a lot of people that were doing 12-step outreach, and people that were volunteers, formerly battered women, and people that were formerly battered and also experienced substance use, were really willing to help support survivors. So this is something to be thinking about. The other thing we found out, of course, in the beginning, we had that one little grant for $5,000, and King County has over 1 million people in it, and we were the only game in town. And it took us a while to be able to get the resources together to have an actual shelter devoted for people, and treatment settings that were able to provide services for people with domestic violence and sexual assault, things along those lines. It took us 10, 12 years to build things up. So in those early years and now to the present day, the women themselves have created follow-up groups and second stage groups so that they continue their early work. And I just wanted to let you know that peers are very capable and well able to do follow-up work. And we found that alumni from treatment programs, as well as formerly battered women, often could lead the groups with support from the program. So this is just something for you all to be thinking about when you're thinking about next steps. Does anyone have any questions before we move into the next section here? All right, I don't see anything, but if it pops up, Jen will let me know, or Aaron. So in terms of general tips, I think Barbara mentioned it, that it is really great if you can get some of the advocacy and substance abuse skills to work together. And it reduces a lot of opportunity for making a mistake. It provides a better likelihood that that person's needs are going to be met. And it also helps people feel comfortable to know that if they're struggling with substance abuse and DV, as well as the sexual assault issues, that there are people there that can relate to what's going on. The thing I think is wherever you're trained, you tend to see things. Like for me, you know, if I'm working as a substance abuse professional, I eat, sleep, and breathe alcohol, drug issues, and I recognize if someone says something to me like, oh, I can't go to a meeting, I'm thinking, you know, are they wanting to use? Is this a relapse issue? I'm thinking, are they getting, you know, off the pink cloud and getting into recovery is no longer a gift to myself but a problem? I'm going off down that lane. But when I have my battered women's advocate or survivor of sexual assault advocate hat on, and someone says, I don't know if I should go to the meeting, or I don't want to go, I might be thinking, has someone made a threat? Has someone said you're not allowed to go? Is someone preventing you from attending? So I'm looking at it, a single statement, from a different point of view. And even when you're someone like me who is trained in two fields pretty thoroughly, you still you can miss things if you're focusing on one thing rather than another. And I remember, I might have mentioned this in another webinar, so if you heard it, I apologize, but I remember one of the women in our group telling us that she was going to pick her husband up at the hospital. And what concerned me was that she had managed to stay away from him for about a year. That was her goal, because he is a highly lethal individual, really scary, and he'd already been arrested for a homicide. And the other thing is that it took her a long time to get clean and sober. She'd been in and out of you know, domestic violence programs, and had been asked to leave due to substance use, and over time had been able to get both safe and sober. But how she maintained that safety was she didn't feel that she felt if she completely cut off contact with her husband, that it could be really dangerous. So she should, you know, allow him to speak to her once a month or so. And she was able to rack up, I'd say, about 1.5 years of sobriety and good lot of safety time by managing that way. But she never, in the whole time that we worked with her, expressed interest in going to see him. And so I was a little anxious, and I was thinking like an advocate, and I started doing a safety plan with her. And I remember saying, do you think you'll be safe going there? And she laughed. She said, I think probably with him in the hospital is the safest time for me to come and see him, if, you know, when he gets out of surgery. But there were women in the room who were in recovery, and they said to her, that's great. It sounds like you got a safety plan and you know what to do and everything. And then one of them said to her, but tell me this, you know, you're going to the hospital to pick him up, and he called you. Did he say, I will give you some pills? Did he say, I would share my meds if you pick me up? Did he try to undermine your sobriety and, in effect, nearly get you dead if you do take those pills? And I can still remember her face just fell, and she put her head down and she started crying, because that was a question I didn't ask her, because I was in DVSA, you know, domestic violence sexual assault mode. And I thought, God, you know, I've been working in the treatment field for all these years, but I just got off track that day. But the people in recovery were able to see what was really happening. And this is why I think the interdisciplinary groups are really helpful. And to be well aware that people who hurt others, they don't want people to get clean and sober. And in fact, it's a myth to think if you get into treatment, you're going to get safer if you have an abusive partner, because your abusive partner sees your escape from substances as an escape from them as well. And it puts you at greater risk, and in fact, some of the physical violence and emotional abuse escalates as people get clean and sober. And so we have to be really rigorous in the treatment setting as well as in domestic violence to watch for safety as well as risk to sobriety. These are things that are important. Barb, did you have anything you want to add around that?
Yeah, Patty, that sounds really good. That you can miss what somebody's talking about if you have one lens. So it's real important to have both lenses there, two different people.
Yeah, it's really important. And that's why I think, like, we always try to co-facilitate, and which we mentioned, and we like to think kitchen table, and we like to have options for people to be able to deal with practical issues as well as with clinical issues. And believe you me, anything can come up when you're doing an interdisciplinary group. It's something to be thinking about. In terms of practical issues, if you're in a DV setting or a shelter setting, or I would really say if someone's got paperwork or issues to deal with, it is okay. We've always let them use the copy machine or the phone or the fax, etc., things like that. When you're in a treatment setting, I think it may be more challenging. The needs with sobriety, part of empowerment would be structure, and yet structure that where a person has input is usually going to be more effective than arbitrary structure. But there are ways that we can provide practical support and structure in a treatment setting. And while it may not, in early days when you've got someone new and they're really struggling with early recovery, it might be fine to deal with some of the practical things and do things together as opposed to just give someone free rein. But instead of just arbitrarily making that rule, to talk to the person. I used to, when I worked in the treatment side, I used to say, can you think of any reason right now when you're only 3 days into the program it might not be in your best interest to just get to do X, Y, and Z whenever you like? Can you think of any reason, and how do you feel about that, and what can we do? Just to spend time thinking, helping them think it through, and helping that person feel invested and understanding why the guidelines are set up the way they are. There's different tasks to be achieved when you are working on the treatment side, and there are different tasks to be achieved when you're working in the advocacy side. But we can work together and figure out ways to address both safety and sobriety if we're open and willing to see how these things support each other. Just getting sober will not get you safe, and just getting safe will not get you sober. They pose risks if we're not working in partnership with the survivor. Barb, did you have something to add?
Yeah, I'm sorry. Yeah, I'm sorry. The one thing I wanted to add was just that sometimes the rules within the structure we create can mimic abuse and abuser tactics, like not being allowed to use the phone or do things. And so to try and utilize the group members for what rules are important to have and what rules are too controlling, feel like my abusers kind of rules before you institute a lot of rules in a group.
Yeah, I think that's really important. And for me, I find that depending on what setting you're working in, a treatment setting can actually, it can often more easily build on prior group work, and you can get a little more structure and be a little more consistent, because you might have a group of people over a period of time where they begin to get closer to each other and develop things as a group. Whereas if you're doing drop-in groups, or you're in, in a shelter, you may have someone that depend anywhere from 30 to 45 days, sometimes longer if you've got transitional housing or other kind of grant funding that'll let you work with someone longer. Transitional housing is longer. But a lot of times in community-based groups, you might see that person one time, or you could see them 12 times. The average group member used to attend our drop-in groups about 12 times. and then they would feel they had enough and they would move forward. But we had a significant group, probably a little over a quarter of people that attended for years. And we didn't see that as fostering dependency, but similar to what someone might say who works a program, like a AA or an NA program or other type of program, White Buffalo or White Bison, I should say, or there are other programs that people work, and where they feel they need ongoing support. And so we would have some people that come in once or twice and some that we keep working with over a long period of time. And it's a very affordable support group if people feel that they're getting their needs met and can carry through the week, maintain their safety, maintain their sobriety if that's what they're seeking, or at least engage in some harm reduction early. There's a lot that can be done. So I just want to tell you that there's a lot of different ways to work this. And I already mentioned that the stage 2 groups can be led by women themselves. And so I want to talk to you about what we found to be the general goals. So I want to talk to you about both in terms of advocacy and also on clinical outcomes. So if I were talking to you as alcohol drug counselors and as well as advocates, it's in the sense of what we hope to achieve in a support group where we're talking about domestic violence, sexual assault, and substance abuse. For women that their primary concern, or where they have identified they've taken themselves off to a treatment setting first. Many times people will go to treatment instead of shelter or a rape crisis line if they've determined that they have the most to lose from their relationship with a substance, or they're more afraid of what the substance is doing to them. So they may see their primary aggressor, their principal person that's hurting them, is the substance as opposed to the batterer or abuser or person that's hurting them. And so generally when someone goes to treatment, sobriety, or at least harm reduction maybe initially, and then sobriety ultimately, may be the goal that they're seeking. And so when we are talking to them about issues regarding domestic violence and sexual assault, we're going to be talking to them about it in the context of how that behavior and what is happening in their relationship and what has happened to them in the past or as children or now is affecting their sobriety, and how it can be undermine their sobriety and what can happen. So we're going to be framing, we're going to be talking about both domestic violence and sexual assault along with sobriety, but we're looking at sobriety as the major issue for the person until they tell us different. If the people you are working with are people that are attending ongoing group at a sexual assault center or a rape crisis program, or they're engaged in a domestic violence program, or in a transitional transitional housing program for someone who is experiencing domestic violence, but they're also using substances, etc. We're going to be focused primarily on the issues of safety, on domestic violence and sexual assault and what has happened and how we can help them safe. And we're going to be looking at substance use and a substance use disorder in terms of how it may be a form of coercion, how an offender or a person who hurts them may use the substances against them, and how, like, for example, experiencing a blackout, not being able to remember what happened, or having gross motor deficits secondary to substance use, where you can't run as fast or you don't feel pain as much, or if you're on coke or methamphetamine, you feel stronger than you really are. We're going to be talking about those things in the context of your safety. And over time, what generally happens when you're working with people, whether they're in domestic violence and they're looking at their substance use issues as a safety concern, or if they're in a treatment setting and they're looking at domestic violence as a sobriety issue, many times they determine that they need help with both. But they get to decide. I want you to know that when I first started doing this work, I came into the field as a substance abuse counselor, and I really thought if everyone got clean and sober, everything would immediately get better. But actually, domestic violence and sexual assault issues seem to get worse. And that was a shock to me because, you know, you're told that if you stop using, everything improves. But if you stop using and then you try to leave your partner, you know, your risk of getting dead from something else goes up, or the type of violence that is occurring is more dangerous. And if the partner was able to use substances against you to get control in terms of sexual abuse or engaging in unwanted sexual activity, and now you're fighting him off or her off, as the case may be, your danger increases, and the risk for physical and emotional harm gets worse. And for women who, or men, as the case may be, who are using domestic violence and sexual assault programs, if they decide they want to stop using so they can get into that program and last, and they find themselves with withdrawal issues, it gets really dangerous. So one of the things that we found out was that there's a lot of similarities between domestic violence, sexual assault, and substance abuse. What happens when you're trying to escape from whether it's the substance or the person, that like trying to stop using can be lethal, trying to get away from an offender or a person who hurts you can be lethal. And that if you're trying to do both together, 1 + 1 again creates even greater risk. And so it sometimes takes 2 and 3 times longer to do half as much. And people who are working with survivors that are dealing with substance use and interpersonal violence, they often think, oh, they're not getting it, not much is happening. And what I want to tell you is the littlest things are major big deals for people experiencing multiple forms of abuse. So in order for you to get any clinical work done as a clinician, as a behavioral health person or substance abuse practitioner or mental health person, when they've experienced trauma from interpersonal violence, the person has to feel safe. And you do not feel safe like automatically, and it doesn't, if you might feel safe on Monday and not feel safe on Wednesday, but we have to do safety check every time we do group to find out where that person is. And that until the person feels safe, they're going to be guarded, lack trust, not be able to open up, and they will hide things. And so it's going to be really difficult to support sobriety or anything else if that person doesn't feel safe. And I would say to advocates, and I think you all know this, advocates, that safety is not a place, it's not the shelter, it's not, the house with the locks. Safety is a state of mind. And on some days, people may feel more safe than others, but before they can actively engage with us and work on a safety plan and share what their concerns are and trust that we're there to support them, they've got to feel safe. Safety, if you look at Judith Herman's book, Trauma and Recovery, is the first goal, both for advocacy and for clinical work. And then I think for both domestic violence and sexual assault and treatment, not only do you need to be safe, but you need to be able to tell your story and be believed. And I think that that's one of the similarities between the battered women's movement and the sexual assault movement and early work that was done in the treatment field, is that peer groups were the basis of it, the backbone of it, and people could be around others that went through what they did, not feel judged and not feel demeaned. One of the most powerful moments for me that I ever experienced when I was participating in a group in Washington State was a woman who had come in and she had experienced child sexual abuse, had been forced to be involved in the sex trade, and had a significant alcoholism and a lot of addiction to opiates. And she came into group, I think she came in 3 times, and every time she came in, they asked her if she wanted to check in, and she declined. And then I think the 4th time she came in, they asked her if she wanted to check in, and she declined. And one of the women in the group was having a difficulty, and she asked this woman that I'm telling you about, did she have any ideas that would help her? And I think she was kind of stunned, and that anyone would ask her opinion, and she shared her opinion. And the whole group clapped because she gave some really good, sensible information. And of course, the group guidelines is these are suggestions, you don't have to do anything, but she was asked and they told her that that was the best advice, and she said she was going to, the other woman said she was going to try it. And then this woman put her head down and she started crying. And I was like, what's going on here? You know, I wasn't expecting that. And what happened was she sat up and she said, I am, 33 years old, and in my entire life, not once has anyone asked my opinion about anything. And she said, when I came in here, I couldn't even speak the first 3 times I was in group. I couldn't even speak. And I didn't think anything I had to say was worth anything. I felt lower than the rug. I felt like nobody. And I felt like anything I had to say would just be laughed at or put down, and I felt so alone. But now I know different. And we were looking, and she said, yeah, I felt smaller than the rug, but somebody valued my opinion, and I don't feel alone anymore. And she said, because I think the first week we were talking about, I think we had the power and control wheel out, and we were talking about the domestic violence movement in the substance abuse field. And she had got that information about the battered women's movement for the first time. And she said, now I know I'm part of something bigger than myself. I'm not alone. I'm part of the battered women's movement, and I'm also part of the recovery movement. And together with those, I can't miss. Everything's going to get better. And I mean, it didn't get better right away, but she was able to stay with that group for a very long time and maintain her recovery and maintain her safety. And I always think of her just saying, I'm not alone anymore. I'm part of the battered women's movement. I'm part of the recovery movement. They march together very well. So it's not just safety and it's not just sobriety. People need to be able to speak. They need to tell a little bit about their story and be believed, because whether you're a therapist, a clinician, a treatment provider, or an advocate, when you're dealing with multiple abuse, you're bearing witness to the harm that's being done to people by others as well as by substance. And so you're validating that experience, and you're letting them know it's not their fault that they are that they were a victim of substance use, nor a victim of domestic violence and sexual assault. That anyone might use something. Not everyone becomes addicted, and if one does, one develops a substance use disorder. You know, there's biopsychosocial and other factors that contribute to that, and that while you're not responsible for having this problem, you have the power to make choices and changes, and we can support you. Those are really important messages. And for those who have partners who are hurting them, to know that they're not responsible. They didn't pick this person out. They didn't ask for it. And that while they're not responsible, they get to decide how they proceed, what is safe for them, what they do, when they do it, whether they leave or they stay. But we're there to support them because we acknowledge they know what's best. Those are really important messages, because messages people that experience a substance use disorder or interpersonal violence are usually very negative and shaming. So safety, sobriety, and connection are critical elements. They're clinical needs in order to be successful in this work, and yet they're also incredibly important in order to provide advocacy and not be us and them, but to be able to provide relational support where people feel believed and supported. Now, you know, if you're working in the treatment setting, that it's perfectly normal to not be truthful about how much you're drinking or using and to try to cover up. And I think part of our work is to acknowledge that that's what people do. That's a reasonable response when you're afraid to stop using and afraid to be open and honest and afraid to really address what's going on. But because we work in the substance abuse side, we know that if you share with us things that frighten us, we're at least going to express concern. And it's really important because survivors will tell you over and over again that have experienced substance use, if someone comes in and they smell a booze or they've got injection sites on and no one says anything, it's the same thing as if someone shows up in treatment and they got a black eye or a tooth knocked out and no one says anything. You feel invisible. One of the women I work with told me that she felt like, and she's in a rural village in Alaska, she said, I feel like a walking, talking, invisible, unable to be heard person because nobody sees me, and if I tell them some weird story, nobody ever says, I would say the same thing, you must be scared or you must be afraid. And I think it's real important to make it as safe as possible for people to be able to tell you what's going on. So these are things to be thinking about in terms of the groups. Barb?
Yeah, I just wanted to add, Patty, that the women can be very good for supporting each other, but if they start exchanging phone numbers, you just want to talk about safety around phone numbers, because you can call someone if you feel like using from your group that supports you, but if you're still with an abuser, could that be dangerous? And so just talking about phone number exchanges with the whole group, as well as if you have developed some type of list for people to have, that you also think about safety in regards to people's phone numbers.
Yeah, and that is something that comes up in group a lot. And what a lot of the women in the support groups have done, some have declined to participate in it's not been safe for them to share their phone numbers because of abusers or people that hurt them. And so that's been an issue. For some, though, they've come up with ways to do it, to make the exchanges, and they won't necessarily write the person's real first name. They kind of, like up in Alaska, we had named everybody Flowers on one group thing, so they had flower names. Although I got to tell you, don't use Alaskan Poppy if you're doing an alcohol drug group. That was like, that took everybody right off into drug thinking rather than, so stick with Rose or a flower doesn't have drug connotations. But so you can do that. The other thing women did was they put the names under their gynecologist, or they put it under things that would seem really innocuous or not as, like, it didn't go in the friend thing, or it would go under school or teacher, or some weird thing like that. They would figure it out. They were really good at figuring out how to safely connect with each other. And that brings me, to another thing. Like, a lot of people are really afraid, and like I told you, relationship is what helps people get both safe and sober. And there were a number of people over time that, they would just wish the whole group could go with them to court if they had to do a protection order or something. Because, like, alcohol drug counselors and behavioral health people are well aware that stress equals craving, and craving is followed by use if something doesn't interrupt the pattern. And if you're in a domestic violence situation or a sexual assault situation and you've got to go to court, there is stress. And if the stress is going to accelerate, if that person has substance use disorder, the stress is going to accelerate. And if we don't factor in that stress is there and build a way for people to feel connected or have a way to address the desire to use to cope with the problem, we're going to see over and over again. I know we probably got attorneys here who will tell you they've worked with someone, they were in great shape, the big day came, everything was fine, and the person either didn't show up or showed up so loaded or so under the influence they couldn't put them on the stand or help them with their custody or anything else. And what we found is, what the group came up with was a plan where, like, if something that was scaring them was coming up, what they did was they did make a phone tree. And they set it up so that they say, okay, we can't go to court with you because we're at work or whatever, we're all doing different things, but we can go with you in spirit. And so they would write a positive message telling the person, we're with you, you're not alone, you call us before you go in, you call us after. If you're thinking of using, here's something else you can do. And they would write these beautiful messages of support, and those that could would leave their number, some couldn't. And the person would fold that up and hide it in their shoe or put it in a secret place. And, like, when their hands were shaking, I've had women tell me their hands were literally shaking, and when they took that paper out and looked at it, they felt stronger and they were able to function and they were able to get through it. It got to the point where I actually put it in the support group manual, how to get these lists going and tools that you can use to help people reduce isolation and feel safe going to court and other places. This was probably the most useful. Anytime someone was overwhelmed about something coming out, the group would just say, Patty, get out the paper and pen. We want to make the messages so this person is not alone and they're going to get the support they need, and then they can report back. And we would also encourage them to talk to their clinical, their clinical counselor, to contact the shelter or the advocate on duty, to have a number of options so that they weren't isolated alone. And we would ask them to write down things that they had done when they were unable to drink or use before, when they were frightened, how did they do it, what did they do, could they do more of that, and that was very helpful. Now, in terms of doing this work, it's going to look different depending on what setting you're in. And the alcohol drug counselors and behavioral health people that are on the call, we've done these groups inpatient, outpatient, and in long-term care, like a perinatal treatment center in Seattle and other settings. We've done them in methadone clinics, and we've done them straight up like a clinical group with an advocate present to just respond to safety needs. We've also done them as kitchen table groups or self-help groups. It depends on how you want to operate it and how you want to set it up. The information that we have, I have put in the support group notes when you get toward the end. You can't get everything you need in an hour and a half on a teleconference, but I knew you'd probably want this information and the specifics and the practical dimensions and how to actually do the work. And so what I did is I put in the manuals that work really well, and I put in how you can get to those manuals online. And also Jen has for you a list of excellent resources and the direct links to them. So in terms of the support groups that I do and my friends do from Washington and Alaska and Illinois, we've been, and I would say Iowa too, Iowa's been using a lot of the materials really well. And British Columbia has been using a lot of our work. And British Columbia also, up in Canada, has been putting together some phenomenal materials that you may find really useful. And one of the things I really like about Canadian programs and their work is that they're really good at being inclusive in terms of First Nations people and also in terms of looking at the cultural dimensions. They're very, very good at it. And I would really encourage you to look at the, used to be BCYCHC, but it's now just British Columbia, the organization. And I have put the link to their programs here as well. I love their work. And you're going to like the work. The groups that we do are in 3 or 4 different manuals. I just picked out 7 here to give you some ideas of things to be thinking about. But we have 16 groups in the recent responding to multiple abuse, and I think in the safety and sobriety manuals we have 16 in one and 12 in the other. All of the work that we do you can access either through the National Center on Domestic Violence, Trauma, and Mental Health website, or through the Alaska Network on Domestic Violence and Sexual Assault. And the Alaska ones, when you go in there, they have the materials both in English and Spanish, because everything we've done we put in, we have had translated into Spanish as well. And most of the work on the most recent manuals, we had a lot of input from the Women in Recovery Caucus out of Washington and from National Indigenous Women's Resource Center, and from Native organizations in Alaska. So I think you may find them very helpful when you're doing the work, particularly since some of the early work was more urban, but the most recent manuals I have a lot of tips regarding work in rural settings, so they will be helpful. You're going to structure these groups in different ways depending on where you are. In an inpatient setting, I usually had, like if I had them for 3 weeks or 4 weeks, when I was working at perinatal, I might have the same, there's an 18-month program at times, or 12 to 18 months, depending on how long the person was there. We might be doing pieces of groups over that length of time, and there might be some repetition. We might be bringing other things in, but you could build on it. It had a building blocks because you pretty much had the same people throughout. And so you can really help work with the person, take it slow, instead of maybe doing every handout, just picking one thing and helping them through it, and working with them and linking everything to their primary issue. Usually the primary issue in treatment setting is the substance abuse, so how these safety issues affect them. And what we found in alcohol drug treatment when we were doing groups in there is that many survivors of domestic violence and sexual assault would come into treatment programs, and they might have had arrests for domestic violence charges, or they might have come in and they say, it takes 2 to tango, I'm as tough as my partner, I need anger management. And what we found is if we rush people into anger management, female survivors into anger management without helping them recognize the experience of harm that they had, that their relapse rates were really high. The dealing with anger and making it like a really bad thing is not particularly healthy initially. If you're working with a domestic violence survivor, what you want to do is validate that they've been harmed, then address anger and look at safer ways to respond. And so it's not that people might not benefit that are women from anger management as a treatment issue. But I think before you rush people into anger management, we got to do a better job at screening for past history of domestic violence and helping them validate what has happened to them. A lot of them that I've worked with in treatment settings have felt stronger by expressing anger and to identify that they were hurt or frightened or scared. Is really overwhelming, and it's a clinical, I mean, in a treatment setting we would call that a clinical issue that's going to take time to work with and process and help that person feel safe. We know in alcohol drug treatment generally people will say anger will take you back to using, but for battered women and survivors of sexual assault it's reasonable to be angry, and you have to let the anger be expressed in a safe way when they're not drinking and using, so that they can move on to the grief and loss issues that came from the sexual assault and the battery, etc., and then move forward to empowerment. Because I think for people that have been marginalized or who've experienced sexual assaults or domestic violence, that that marginalization is as big of an issue as what we might have looked at in terms of anger in the earlier days. So anyone wants to talk about this or address this, I'm thinking about doing a webinar on some of the differences in treatment approaches. You know, we're just like looking at women's anger, you know, when domestic violence and sexual assault is present, and how to do a better job with that on a clinical level. Now, for those of us that are working on an advocacy level, what you find out is we know that in general one of the biggest pluses of participating in a domestic violence and sexual assault program is, again, linkage with others and that sense of bonding that you'll often get from peer support. And I think that's not untrue in substance abuse as well, similarly. But the thing that we find seems to be something we take for granted in our field is that women do feel connected and can get support from each other. And what I have found in alcohol drug treatment, there's not as much gender-informed treatment or treatment that's specifically for women as would be ideal. And that many of the women that I've worked with in the alcohol drug settings, they don't necessarily find other women as their friends. This is, I don't want to make a sweeping statement and say that's always the case, but many, many, many women that I work with in a treatment setting, they start out with all my friends are men and I drink as much as a guy and I can do, and these kinds of comments are not unusual. And I find that because alcohol drug treatment, you know, you're often labeled as a bad mother, or co-core, slut, you know, really ugly names that a person shouldn't have to have. That so much of the treatment, you're dealing with an illness that anyone, male or female, might have, but for women, the illness is you need half as much, or considerably less substances over a shorter period of time to get to experience lethal substance use disorder. That so you'll see people extremely in extremely serious situations, quite much younger than for the majority of men. They experience the same illness, but it manifests itself differently. And yet I would say that healing from substance use for women means healing how you feel about other women and not feeling marginalized because of your gender. And so the domestic violence field can do an awful lot to help people begin to reclaim and value themselves as women. And I think this is common in Native programs, Alaska Native programs, and in programs that work with NIRIC around the country where you will see women are really given opportunities to validate and claim their power rather than misuse it. So these are things to be thinking about when you're doing group. What setting am I in? If I'm in a treatment setting, I'm going to be looking at clinical issues, but how does safety affect the person? And if I'm in a domestic violence, sexual assault arena, how is a batterer or a person that's hurting this woman or this man, as the case may be, how is this person using substances to prevent them from getting safe? Are they using coercion? Are they forcing them to trade sex for drugs? Are they taking money and that should go into the house and using it? Are they forcing people to use more than they want to? Are they forcing themselves to use? How much sexual abuse is happening because the partner is forcing them to take on board more alcohol or drugs than they want to? And if we don't look at those things, it's almost impossible to help that person get safe. And if you're on the treatment side, if you're not aware of how batterers use substances against their partners and how they contribute to addiction, because they want that person to have that substance use disorder and experience stigma, you're just not going to see a successful result. So these are things to be thinking about. Any comments, Barb, or questions?
One thing I wanted to talk about was sometimes in the with the substance abuse counselors involved in Iowa anyway in doing groups with domestic violence and sexual assault advocates, one thing that comes up is whether or not women feel safe around having a male facilitator in one of those groups. And in some of the rural programs, they may only have a male available to do the group. But I think women in domestic violence and sexual assault may not feel, in the context of that, may not feel safe around a man, but in substance abuse treatment they do. They don't trust women as often because women would go after their man for drugs and sleep with them and stuff like that, so they tended to shy away from women. Well, so co-leading with a woman and a man we've seen be successful, you know, or just have two women leading the group. But if you co-lead, then you could have one woman and one man, and it is successful sometimes.
Yeah, I think you're right. I know. I think that it's hard sometimes in rural programs to have all the programs don't necessarily have the capacity that's needed, but I think in terms of if it's possible to provide, I think what the data shows is that men do well whether their therapist is male or female, but women have a harder time with men in the support group. I don't know. I mean, I haven't got the data. I haven't got all the data with me right now, but it's things to be thinking about. Really, whether or not a person feels safe or not. It's not. I think a lot of times, when I first started working in the field, if someone asked for a female counselor, sometimes people would roll their eyes or whatever. But I think that every program should ask if there's a preference. You know, if you want someone of the same gender. You know, rather than just assume. And it's just, again, not because you want to do preferential treatment, but people that are marginalized often need a different level of support. I mean, it's kind of interesting. If you've been marginalized in any area, you know how the system that has power works. But if you're in the group that has power, you don't always know how the other side lives. And it's more difficult to address some of the concerns. So, again, I don't want to diminish the efficiency and effectiveness of people of either gender, but I think it's important to be aware that sometimes gender-informed counseling with someone of the same gender can be more effective. Just something to think about. Yeah.
And you're not going to want to tell your deepest, darkest story to, not always want to tell your deepest, darkest trauma to a male counselor too. So
yeah, well, if the offender is male, that's the case. I mean, you could have people in same-sex relationships, and that's going to change how the dynamics are and what's going to be safe and what isn't. I know in our early groups, we I often tried to have you know, people that were reflecting the diversity of the participants of the group. So I would often like have, I might put, I had, in the groups that we did, we were able to get people like that were fluent in 7 different languages, that came from different cultures and backgrounds, that spoke, like I mentioned, languages that we recruited women who were bi and lesbian as well as gay men to work on our project, so that if somebody, and you don't want to assume that everyone's going to want to go to someone that is of the same background or ethnicity or those types of issues, but it's nice to be able to offer the option if possible. And if you're unable to employ everyone that that would reflect the diversity of your group, it's really, really good to actively recruit volunteers that can support people. And I was very fortunate because I had about 7 or so people that worked on our project over time, but also we recruited probably about 30 or 40 people as volunteers that were willing to work with people that wanted specific kinds of support and assistance. And it wasn't unusual for us in a support group. You know, we might have 8 or 12 group participants, but we might have 2 group leaders and 2 people that were also there because the group might have been, like if I had a group that was primarily, of a particular background or something, I might recruit a couple people from that would help people feel safer or that could be available. And it's interesting, I know initially, I'm kind of like one of these repressed Irish Catholic type people, grew up in the West End of Syracuse, New York, and kind of like conservative in a lot of ways. And my friend was actually from Brooklyn by way of she's also Native American and a lesbian. And so we were doing a support group, and at one point that primarily consisted of a bunch of kind of older women who were kind of religious, and a bunch of women that were like in the gay, lesbian, bi community, and a couple of guys. And we thought that all the little old ladies that were from my neighborhood would all talk to me and that the others would talk to her. But in actual fact, by co-facilitating together, I think we created safety. And it actually turned out that all of the real conservative little ladies with hats like mine were talking to her, and I was talking to everybody else. And we thought about it, and we realized that by being together, we helped create safety and model that you could have relationships and demonstrate care for each other. And yet they knew if they ran into me in church that I would know their business. And her, people that we thought she would be primarily working with knew that they'd be running into her, and they felt more comfortable, like just having their one-on-ones and stuff with the opposite party. So we learned a lesson that way, not to assume, but to create a sense of space and safety so that people have the option, and where the people that are providing the services reflect the diversity of the group members. I think it's really important. And if you don't have staff to reflect everyone, you want to recruit people that can provide support or offer help. I know in Washington State I had a lot of help from the African American community with Project MIC, where we had African American clergy supporting people that weren't necessarily happy in standard groups. And we had people that were bilingual or trilingual who could work with people one-on-one or be present and serve as interpreters, things like that. I think that's really important. So I know I'm getting through this a lot slower than I thought. I may have to have Jen schedule a part 2 and do some more of this, because we're covering a lot of the very basic parts. But there are a couple of things that I would like to get over to talk to you about before we close. One thing I have found in the groups, whether you're in treatment or in the advocacy program, that again, it's always good to go over the confidentiality guidelines at each group, and to open the sessions by asking each group member to state one thing they did right or that they were proud of achieving during the previous week. And I like to do that because if you've experienced a substance use disorder or domestic violence or sexual assault, a lot of times you don't feel so good about yourself, or you've got someone telling you there's something wrong with you, or you're feeling guilty or shame or what have you. And I think by actually starting each group by talking about something they did right or they're proud of, it reframes things, and people begin talking about building that more successful identity, and I think that's really important. And the next thing that we like to do is find out if someone's facing a particular challenge or has a particular goal they like to achieve. Now, if you're in a treatment setting and you've got regular goals and you're dealing with things, this is probably less important. But if you're in you may want to find out, if there's something pressing. But if you're doing a drop-in or you're in a shelter setting, you almost always have to get into the particular goals or challenges that are happening right now. It's probably true in outpatient as well. They could have anything going on like a DWI rule, or there could be any of a dozen things happening. But when you're in inpatient, I think a lot of times you're working on a variety of goals in various settings, and that may be less critical. It's also important if it's a drop-in to find out what resources they're already using and help them develop additional options to resolve the problem. So sometimes we would just spend a limited amount of time doing this and then move into a more educational component of the group. And I would say in terms of if you were working in an alcohol drug treatment setting, you got a couple of options. And these are things I want to tell the alcohol drug people. We're supposed to do lectures as well as support groups. So if you don't want to do it in a group way and feel more comfortable co-facilitating on educational components, it can sort of be done as an educational session with options for give and take and conversation, a little bit of lecture, a little bit of training, and then a little bit of hearing from them. And that works very well because we're supposed to do X number of lectures and not supposed to do all video. So I find sometimes that bringing in the advocate, particularly if you're in an inpatient setting, or bringing them in once every couple of weeks or once a week or once every 3 weeks, however you can swing it, is really helpful. If you want to run it as a support group, that's a good idea too, and it's best to do the co-facilitating whenever possible. And if you're doing it in a treatment setting, of course you're bound by 42 CFR, but pre-treatment services and lectures, as well as after, when you're not in treatment, if you're going to shelter and you're doing an educational piece and it's just for relapse prevention or peer support, you are bound by confidentiality, but you don't fall under a lot of the records-keeping guidelines that are necessary that you would have to do if you're in the actual treatment setting. For those of you who are alcohol drug counselors, I put in the manual, the safety and sobriety manual. I put in the handout material for you, the link to the State of Illinois Safety and Sobriety Manual, because it has clear-cut suggestions for alcohol drug counselors of what they could do if they're working in a treatment setting on DVSA issues. And the same for it assumes you already know, the alcohol drug piece, and it tells you things that will support your work. And then for advocates, that particular manual has got a good overview of, they assume you already know the DV and SA stuff, and they give you the information pertaining to what would be useful to know in terms of substance abuse. So that would be good for you to have. Now, we got a power and control wheel that also includes the substance use issues. That's really important. And I would say probably the power and control wheel that Jen is providing with you along with the slides today, and the manifestations of violence are two really good tools to use when you're doing the groups, because for many people, whether you're on the DV side or the alcohol drug treatment side, the DV people may not have thought of the fact that the person has forced them to use more than they want to as a domestic violence issue, and the person that's working in the alcohol drug sector may not have thought of the fact that, say, a person's partner has taken money and used it for, they might know that the person's partner might have taken money that should have been used for food or the kids or the housing, and used it for drugs or alcohol, and might not have identified that not as part of the family but disease, but also as domestic violence. So there are a lot of things that really illuminate what you're experiencing and help you do your work in your original field, because we tried to set up the materials for the group so that they were useful regardless of what setting you're in. But if you're in the setting you're in, you start out with, say if you're in treatment setting, you start out with alcohol, drug, and then link the DVSA. And then if you are in the DVSA arena, you start out with that and then link in how the substance abuse is affecting what people are trying to achieve. And then the closure, you want to end each group by asking persons to name one thing they can do to keep safe and sober for the coming week. And the other thing that I sometimes do is I say, imagine that a person is your best friend or your daughter. What would you tell them is the most important thing they could do to keep safe? And then a lot of times people are able to come up with that. And we may very well, again, we may ask what you would do to keep safe and what you would ask to keep sober. If you're in a DV setting, and if you're in a treatment setting, we would ask what can you do to keep sober and what can you do to keep safe. Now, the good news is that I have 3 manuals with many, many clear-cut explanations and descriptions of how to do numerous groups. They are all free. All the manuals are free. And the instructions on how to actually do the groups and the information that will support you are written down, and the handouts are there. For most of the groups, there's 2 or 3 handouts. But you are going to find that you may only need, because people have cognitive deficits in early recovery, and also if someone's experienced domestic violence, they might have a head injury, or they might have experienced strangulation that could cut off blood to the brain and also cause some cognitive problems. Trauma itself, the experience of trauma itself, can make it really difficult for people to think in a straight line. They may be having recall through the senses as opposed to through linear thinking processes. So we have tried to make materials that are easily understandable and short and sweet. Most of the handouts are 1 to 2 pages long. And you don't have to do more than 1 in a group, and you can do bits and pieces. It doesn't have to all be done at once, and it doesn't all have to be done in order. So these are the things that I really want you to know. And so I do know that I have to close now. What I've given you is a brief overview of what the groups look like, how you can do them in different settings, how to start them, how to close them, and what some of the issues are. I've talked to you about partnering. What I haven't shared with you is much information on actually conducting the groups, and I expect that that would be something that you would like. And so I'm going to ask Jen if we can do a part 2 of this and conclude this group in probably next month, September, October, and we'll add that to the list, and I will let you all know when that's going to be. I appreciate that you gave me the time to speak about it slowly and not rush it, because I think that it's more important to talk about the philosophy behind it and how we can work together, and to follow up later with the specifics. In the meantime, you have access to the groups. There is no charge for the manuals, and I would encourage you to look them up. And if anyone wants to speak about them or talk to me at any time, I can be reached here at the center. My email is pjmbland@hotmail.com, and my office phone number here at the center is 315-726-7020, extension 2013. Barb, did you want to close?
You did a great job, as always, Patti. The manifestations of violence I used often and broke that up into 4 different groups, one by each topic, like environmental, social, physical, sexual, emotional, and there's a lot of other suggestions I know that Patti has. If you want to come back to the next webinar, it would be helpful.
Yeah, it would be great, and I appreciate your patience. This is the first time I've delivered this webinar quite this way, and you've been very patient. I think it took me a little longer than I planned, but I didn't want to rush it. So thank you for your patience, everyone, and hopefully we'll get to part 2 and you'll feel happy. Thank you so much, and thanks, Barbara, for co-facilitating with me today.
Thank you, Patty.
And thank you, Erin. And
so I want to thank everybody. Thank you, Patty and Barb, for such an exceptional webinar. Thanks to Caption Colorado for providing today's captioning, and thanks to Jen Curley for making the webinar run smoothly. And thanks for sure for spending your time with the center today. Just as a reminder, I'll be sending out an email to everyone within the next week with all of the slides and information that you saw today, in addition to a certificate of attendance. If you have a moment at the end of this webinar, when you log out, there will be a brief evaluation, and if you could just take a moment to let us know what you thought, that would be so helpful. Thanks again, and I hope you have a great afternoon.